my disclosure is the fact that this is a Olea sponsored session. So over the next 20 minutes or so, I'd like to go over the background of the fact that why do you need to reduce the contrast dose for your DSC brain perfusion. I'm going to show you the feasibility study that we have done at the University of Arizona, and then we will go over some of the clinical applications and show you some cases. So brain DSC perfusion is increasingly used in clinical practice. I think most of us in this room are using it for whether stroke imaging, brain tumor imaging, or as a problem solver in our daily practice. The current standard dose of gadolinium currently is 0.1 millimole per kilogram. And the question is, why do you need to reduce the gadolinium dose for your DSC? I think there are several incentives to do it, but the most important one for my practice is due to increased demand in the use of multi-combined, multi-enhanced MR applications. For example, for stroke imaging, we do contrast-enhanced MRA and DSC perfusion at the same time. And for brain tumor imaging, we do DCE, or dynamic contrast enhanced, to evaluate the K-trans, and we do DSC to evaluate the RCBV. So your options is to give these patients 2 doses of contrast or split the current standard dose and perform both of your sequences. Other incentives to reduce contrast dose is the direct relationship between the risk of nephrogenic systemic fibrosis with contrast dose, and of course to reduce the cost if you can. So what are the challenges in contrast dose reduction? I think there are, again, several challenges, but the most important one is due to the fact that the commercially available post-processing softwares, at least until now, the SVD technique is the most commonly deconvolution technique that is used, and that's an ill-posed problem where small changes in data can dramatically influence your response or residual function. And of course, reducing the contrast dose with resultant lower SNR can further accentuate this limitation. And when Bayesian was introduced by Olea, that was really one inspiration really behind this study to use it, because of the fact that in the literature they showed that Bayesian is inherently less sensitive to low SNR and has potential for more accurate calculation of cerebral perfusion with low-dose protocols. So we decided to use it and give it a try, see if that works. So this was a pilot study that we did to establish the feasibility of a reduced contrast dose DSC perfusion and compare to the result between Bayesian process images and CSVD deconvolution technique. So this was a prospective study. We included 20 patients. We scanned them at 3T. We used same sequence parameters for both half-dose and full-dose scan. This is our image acquisition scheme. So we basically did our conventional imaging first. Then we did our half-dose perfusion using 0.05 millimole per kilogram gadolinium. Then in between, we did T2 and T1 post-contrast images for about 8 minutes. And then at the end, we did a full dose using basically 0.1 millimole per kilogram. And each dose was flushed by 15 cc of saline. We use Olea to process all the images processed by CSVD and Bayesian, and we look at the co-registered cerebral blood flow, cerebral blood volume, and MTT maps in both half-dose and full-dose groups, both qualitatively and quantitatively, which I show you some examples. So in this slide, I'm actually showing the noise and SNR distribution across the field of view in a subject who was scanned with half-dose perfusion, gadolinium dose, half-dose, and you can see that there is significant noise across the field of view. Compare that to the same subject, same slice position, full dose, and you can see that the noise is significantly accentuated in the half-dose group. Our quantitative measurements show approximately 36% lower SNR in half-dose group compared to full-dose group. So this is a real problem. If you give less contrast, you're gonna have less SNR. That's a fact. So let's look at one case here. This is basically the slice position here I'm showing you. These are the perfusion maps, MTT, CBF, and CBV, done by half-dose perfusion on the top, and then performed by full dose perfusion at the bottom, and you can see there is some heterogeneity across the field of view and MTT maps, for example. Here, if you compare that to full dose, you don't see that, or the CBV. There are definitely error and heterogeneity in the maps. If you compare to full dose, again on the other side, there is some underestimation of the MTT, and these are all noise. And then this patient has also a small cortical-based meningioma that you can see on full dose, and you can hardly see it on half-dose perfusion. So let's look at the same patient, same slice position, process with Bayesian. Again, at the top we have half-dose perfusion, at the bottom we have full-dose perfusion, and you can see that the maps are more uniform. There is less heterogeneity in half-dose group compared to full dose in MTT, CBF, and the CBV. The cortical-based meningioma, you can see it on full dose, less conspicuous and smaller, but you still can't see it on half-dose perfusion study. So let's look at some numbers. We did evaluate the perfusion parameters in both gray matter by drawing the ROI over the central sulcus here, and these are basically the result of gray matter cerebral blood flow. At the top, I'm showing you the Bland-Altman plots, and the bottom, I show you the scatter plots with correlation values. And if you look at the difference between the two, you can see that there is less mean difference and narrower range for Bayesian processed cerebral blood flow compared to CSVD process images, and a much better correlation again in Bayesian process compared to SVD process images. Same thing for cerebral blood volume. Again, you see a smaller mean difference between half dose and full dose, as opposed to larger mean difference and better correlation factor. Of course, the value is not going to be exactly the same because you're using two different doses of contrast. And again, if you look at the MTT, you can see much smaller mean difference between the two, and much better correlation when you compare to the Bayesian. And in white matter, as you know, perfusion is less, and therefore the reduced contrast dose can be more problematic even, and that was duplicated in our results. So you can see again much better correlation in Bayesian half dose, full dose compared to CSVD with better correlation, and again for CBV, smaller mean difference, better correlation when you compare Bayesian to CSVD. And look at this MTT map in the white matter. Basically, there was no correlation between full dose and half dose when they were processed for SVD, but relatively good correlation between the two when processed with Bayesian. So this was a 40-year-old man with multiple sclerosis. He had this non-enhancing cortical-based lesion. The question was tumefactive MS or astrocytoma. Therefore, the referring physician asked for a perfusion scan. So we did include this patient in our study. We did both half-dose and full-dose perfusion. And you can see, again, these are SVD process images. On the top, you have the half-dose. And you can see, again, there's heterogeneity across the field of view. When you compare to full-dose, the maps are more uniform. Again, the maps are more heterogeneous when you process with SVD. Compare that, same slice position Bayesian, you can see that the maps are significantly more uniform across the field of view. And if you look at the numbers, so we draw a region of interest in this lesion, and you can see if you're looking at the CSVD process images, there's approximately 2 times overestimation of MTT in half-dose group compared to full dose, as opposed to relatively better correlation between the two on Bayesian process images. And then the CBV, and there's almost a factor of 2 underestimation of CBV using SVD, as opposed to relatively good number between half-dose and full dose when processed with Bayesian. So why are we doing this in our institution? These are 2 main clinical applications that I'm using half-dose perfusion for. So for stroke protocol, as I said earlier, we use combined contrast-enhanced MRA and DSC perfusion. And for brain tumor imaging, we use a combined DCE and DSC. And we just decided not to double dose our patients. So I'll show you our 6-minute MRI stroke protocol. This is what we did over the last 2 years. It's published this July actually in Stroke, if you're interested in more detail. But basically we accelerate the acquisition time by doing EPI-based images with incorporation of parallel acquisition, GRAPPA, and we also use contrast-enhanced MRA as opposed to time of flight. And then, so we use half dose for MRA and the other half for DSC perfusion at the end. So I'm showing you a case. This was a 61-year-old woman presented with right-sided weakness and aphasia. She was scanned 90 minutes from the onset with NI stroke scale of 17. These are the corresponding images from our 6-minute stroke protocol. You can see that there's clearly a left MCA infarction with involvement of the basal ganglia. There is no flare hyperintensity. This was a hyperacute stroke. She was scanned 90 minutes from the onset, no hemorrhage, and a large perfusion deficit if you're looking at TTP maps. This is the MRA images, and you can see there's a carotid T occlusion with basically absence of flow in MCA and retrograde filling of the A1 to the other side. So let's look at the perfusion map. So if you look at the TTP, for which you don't need to do any deconvolution, then you can see that the delineation of this perfusion again is done by half dose contrast. So you can see that there's a large diffusion deficit, but if you're interested in obtaining some numbers and you want to do deconvolution, then for example, let's say you want to do MTT, then you can see if you process the images by MTT, this hypoperfusion is less conspicuous. And again, you see this heterogeneity that is caused by low SNR using SVD technique. Look at the same map process with Bayesian, and you can see much better delineation. You can see the better background suppression compared to SVD and better delineation of perfusion deficit as shown here. For brain tumor protocol, again, we like to take advantage of the complementary role of DCE. So we do DCE and DSC in the same protocol, splitting the contrast. And I'm showing you one example that why we think DCE is important in our practice. This was a 54-year-old man with history of hypoglioma. He was treated with gross total resection with radiation and temozolomide, and he presented with this new enhancing lesion at the bottom of the resection cavity, and the question was radiation necrosis versus tumor recurrence. If you look at the DSC images, you can see that this lesion is located right above the plenum sphenoidale, and there is susceptibility artifact related to airborne interface, and therefore your DSC is not diagnostic. If you do DCE, you can clearly see that there is increased K-trans in this lesion, and has a rapid vascular phase with significant vascular phase. This was read as suspicion for tumor recurrence. This patient was scanned 3 months later. You can see that there is significant growth of tumor. Now you have enough tumor away from plenum sphenoidale that you can actually detect increased RCBV with the value of 5.6 and the increased K-trans, and this was a pathology-proven recurrent tumor basically. So that's why we use this combined technique, and for which we like to use half dose so we don't double dose our patients. This is the algorithm that we use in our institution. We start with RCBV. If the RCBV value of the enhancing lesion is more than 1.5, we call tumor recurrence. If it's less than 1, call radiation necrosis. If it's between 1 to 1.5 or the RCBV is not diagnostic, like the case I'll show you, then we look at our DC images, and then these are the values that we use. So if the K-trans is increased and you have a rapid vascular phase curve, then we call it radiation necrosis. So let me show you one case in which I can emphasize the importance of having a good post-processing technique. So this was a 59-year-old man with GBM, again treated with gross total resection and radiation temozolomide. This was his initial scan. In February 2014, about 5 to 6 months after his resection, he started developing this enhancing nodule along the anterior margin of resection cavity. 2 months later, you can see that there is more enhancement, kind of like irregular, heterogeneous, and significantly more flare abnormality. Again, the clinical question was radiation necrosis versus tumor recurrence. So all of his follow-up imaging was done by half-dose perfusion. So I have processed Bayesian technique on the top and processed SVD technique on the bottom. And again, it's difficult to identify the numbers, so I'm going to show you the graph here. So if you draw a region of interest over this entire enhancing region, and you plot them over time, you can see that there is progressive decrease in RCBV from the beginning, and with the latest RCBV being 0.8. If you look at the Bayesian and if you look at the CSVD, Again, there is decline in RCVV, but the latest being 1.3. So using the table that we use in our algorithm in our institution and reading room, if you look at the Bayesian, this would be radiation necrosis. If you're looking at the SVD technique, this would be in the indeterminate category. This was a pathology-proven radiation necrosis. So in conclusion, a reduced contrast dose to 0.05 for brain DSC perfusion is feasible using Bayesian technique, and Bayesian method is less sensitive to low SNR and can result in acceptable quantitative measurements if you decide to use low dose contrast protocol. And with that, I'd like to thank you for your attention.